Good evening, all. I welcome all the pediatricians who have joined on this Zoom platform. This is Maha Zoom platform. And today we are going to attend this session on difficult pneumonias. As a pediatrician, since PG days, we know pneumonia is like everywhere. We have to treat infectious diseases, pneumonia, we have to know about it. Emergencies, we have to know about it. Acute pyrexia, we have to know it as differential diagnosis. The bugs keep on evolving, the antibiotic resistance is seen, and so we have to keep on learning about the pneumonias every now and then. So no better panel than today's. Dr. S.K. Kabra sir, Prakash Vaidya sir, Parmarth sir, and Sandeep Patil sir. All these stalwarts will be guiding us about the pneumonias, new things, older things, everything. So you can be ready with your questions, listen to them carefully and get your queries clarified. I welcome all on this dais and let's begin with the session. So I like Dr. Gangolia sir, Maharashtra IP President, to say a few words to begin with the proceedings.
Thank you, madam. Good evening, respected faculty, Dr. Kabra sir, Dr. Prakash Vaidya sir, Dr. Sandeep sir, Dr. Parmat sir, moderators, office bearers of Maha team, office bearers of Maha own committee, Dr. Mahesh Moite sir, as well as I see Dr. I saw Dr. Rohit Agarwal sir, past IIP president, joining here, and other dignitaries on this Zoom dais, and all the viewers and dear colleagues on Maha YouTube channel. Welcome each one and all to this episode of Maha Mentor Mentees. The idea of Maha Mentor Mentees was conceptualized by our academic guru Dr. Mahesh Moite sir, and was first organized at a Maha Pedicon and Third West Zone Pedicon and Maha Pedicon 2021, which was held at Alibag last year. This year, when I took over as a president of Maha Academy of Pediatrics, Maha IAP, we, as our president action plan, declared in this year that we were going to organize Maha Mentor Mentees on first Friday of the month since February 2022. And all our programs were done on all Fridays of each month. So we named as it is a Friday releases of all these programs. So we had fantastic and wonderful programs of Maha Mentor Mentees.
Yes.
One can watch all this on Maha IP YouTube channel, and other area of activities which was done can be seen on the Maha IP YouTube channel. So humble request to subscribe the channel. Heartfelt thanks to Dr. Mahesh Moite sir for his help and support to me throughout this year, as well as lots of thanks to Dr. Nilima Bhandarkar for coordinating, communicating, Dr. Vishal Rao to make all the appealing flyers throughout the year, Dr. Neha Singh to make the WhatsApp attractive messages all the year, and Pallavi Dharmadikari madam to give all this technical Zoom support, as well as updating Maha IP website and Maha IP app. And with that, I wish each one a happy learning and let all the best wishes to this episode. Thank you very much.
Dr. Neha Moite sir is there. So, yes. Sir, will you like to say something?
No, I think everything has been said by Dr. Hemant, our IIP president. What is important is this is a probably I think this is the last session of mentor mentee, and we have had almost 10 sessions, extremely highly academic kind of sessions, and nothing better can be taken as a finale. This is like a finale, and who better than Dr. S.K. Kabra sir can be the moderator for this session. And look at the lineup of the faculty. We have the best people in the field giving it. We are very to have this kind of session, and thank you, Dr. Hemant, for giving us this kind of a responsibility and opportunity to host these programs. I don't think I should waste much time. Dr. Kabra sir is there. It's I think the podium and the platform is for him. We want to hear him for next at least 1.5 to 2 hours. Thank you very much. Thank you very much.
Thank you, Moite sir. Thank you, Gangolia sir. Now I'll request Dr. Neha Singh to introduce our today's faculty, and then we can proceed with the session.
Thank you, Nilima ma'am. For today's Mentor Mentees, we have 3 speakers, Dr. Prakash Vaidya sir, Dr. Sandeep Patil sir, and Dr. Parmat Chandane sir. And the expert for today is Dr. Sushil Kabra sir. He is Professor of Pediatrics at All India Institute of Medical Sciences, New Delhi. He is Editor-in-Chief of Indian Journal of Pediatrics. Sir has indexed 640 publications and 170 book chapters. He has also authored books like Essential Pediatric Pulmonology, Essentials of Tuberculosis in Children, AIMS PICU Protocol, Case-Based Review Pediatric Pulmonology. His interest is in cystic fibrosis, asthma, tuberculosis diagnosis, ARI. Now I request Kabra sir to kindly unmute and give his blessings as well as opening remarks of today's topic. Over to you, sir.
Thank you. Namaskar. I am very thankful to Maharashtra IAP for giving me opportunity to interact with so many people and to give me opportunity to learn something more about pneumonias. As we are aware that pneumonia is one of the common cause of morbidity, as it was told by Dr. Gangolia, and it is the leading cause of mortality in the children below 5 years of age. All of us are aware about the identification or diagnosis, etiology, and treatment of community-acquired pneumonia. More than 95% will recover with our initial treatment. A small proportion may require some more investigations and more treatment options. Major problem with pneumonia is that there is no gold standard when we will say that this is a pneumonia. And that is the cause of so many complications in developing a management algorithm. Small proportion may cause a concern in all age groups, and causes of such cases depend on what is age of the child and what is our clinical practice setting. And it may be commonly considered causes in which it is considered, it may be a difficult pneumonia or non-resolving pneumonia, maybe aspiration during infancy, malformations during a neonatal period, unusual etiological agent if there is a immunocompromised host, and uncommon causes due to impaired airway clearance, such as cystic fibrosis and primary ciliary dyskinesia. And as it was highlighted, that we are having an increasing incidence of antibiotic resistance among among the pneumonia patients. However, all these can be managed once we follow an appropriate approach. And I am hopeful that today, as it has been decided to neonatal pneumonia as well as pneumonia in children and pneumonia mimics, we'll learn more about how to approach our patient when we stuck with non-resolving or difficult pneumonia. Thank you very much. I hand over to Dr. Prakash Vaidya.
Thank you, Kabra sir. Now our first speaker is Dr. Prakash Vaidya sir. He is MD DCH, Diploma in Pediatric Sleep Medicine, GCI from University of Colorado. Sir is Joint National Convener of Asthma Training Module, Revision 2021-22. He is co-convener and writing committee member of Under 5 Visas module of IAP. He is also committee member of Writing Antimicrobial Responsibility module of IAP and national trainer of IAP, NTP, TB module and NRC CUF module. Sir was past president of IAP Thane branch. He has 4 index publications and 1 textbook chapter. At present, sir is senior consultant pediatrician at Fortis Hospital, Mumbai and Child Health Clinic, Mumbai. Sir has special interest in pediatric pulmonology. Prakash sir, kindly unmute and you can share your slides.
Thank you very much. Thank you, Maharashtra IAP, for this kind invite, Dr. Gangolia, Dr. Mahesh Moite. And it's such an honor to be with a giant like Dr. Kabra, who is the last word in humility and probably the last word in pneumonias also in India. So it's a challenge to be on the same platform with him. So with, I will try and I'll share the screen now. That I'll be tackling, am I audible? Yeah, I'll be tackling difficult pneumonias in children. And it's a challenge to compress all this in about 15 odd minutes that I'm given, but I'll try. So what is difficult pneumonia? I mean, if the literature gives you a definition of complicated pneumonia, there is no definition of difficult pneumonia. What is difficult? Is it difficult because the child is very sick and difficult upfront? Or is it because we expect get well soon very fast and that's not happening? Or is it a child who continues to worsen despite treatment? Or is it a child with a pneumonia with an unusual etiology? Or a child who is immunocompromised in some way, either with a clearance of mucus problem or some other immune deficiency? Or is it a non-resolving pneumonia on X-ray? So I think it is all of the above. And what are the questions that I'm going to tackle today? Very limited questions. One, can I anticipate a difficult pneumonia? What are my legitimate expectations for improvement in a child who I treat for pneumonia? Is my treatment going to be different initially if I know that there is a problem? And how do I monitor and modify my treatment accordingly? So before I take my cases, and I have 3 to 4 cases to share with you, let me just take a few foundation facts which we all know, but which it will be just a quick revision. That community acquired pneumonia is this acute infection of the pulmonary parenchyma who is acquired in the community as opposed to that who is acquired in the hospital. So however sick such a child is, the bugs are really not the bugs which require very, very high antibiotics. Fever may be the only sign of occult pneumonia, especially in very young children, and you may not get any other chest signs. Grunting is a sign of severe disease and impending respiratory failure. And many times we get wheezing in pneumonia, but wheezing is more common in pneumonia caused by atypical bacteria and viruses than the regular bacteria. Can the X-ray make us any wiser about the etiology? We all seem to have the perception that a lobar pneumonia is bacterial, that a pneumonia that is interstitial is usually viral. But when you look at the studies and the series about this, we find that the sensitivity of an alveolar infiltrate for bacterial pneumonia is only 72% and specificity is even less. Same goes for vice versa for interstitial infiltrates. Just because it is interstitial, the specificity and sensitivity is nowhere close to 100%. It's only 49 and 72. So radiology is not something that tells you the etiology of a pneumonia. However, a lobar infiltrate is reasonably specific, but lacks sensitivity. And one more thing is that we all know what is severe community acquired pneumonia in children. Children with a high temperature who have increased work of breathing, who have respiratory distress, who have feeding issues, who have hypoxia, and whose CRT may be increased. This is as per the BTS guidelines. And I'm just taking a quick look at the treatment as per the IAP guidelines, which have been published lately. And we all know that it is amoxicillin for a child who is outpatient. You may go on to co-amoxiclav. Whereas if the child is an inpatient, and especially if you suspect that there is an MRSA like community acquired MRSA, you would add vancomycin or linezolid, though linezolid is discouraged because it is part of the regimen for MDR TB. And the other thing is that here we all tend to use azithromycin quite a lot. So macrolides in CAP are used only in certain situations where there is poor improvement in spite of the standard line of treatment. And in an immunocompromised host where there is pneumonia, what changes is that we may add vancomycin upfront if there is MRSA and possibly trimethoprim sulfamethoxazole for pneumocystis jirovecii. So with this quick look at the foundation facts, let me just take one last slide for you on this. And that is that how to look at an X-ray. When you see an X-ray, what you actually see, half of the top and most of the top in the left lung is the upper lobe. It's only a small notch of the lower lobe that is seen on the X-ray. So if you see here, this much is the left upper lobe. Only a small one is the left lower lobe. This one is the right upper lobe, right middle lobe, and a very small notch of the right lower lobe. This is just so that we can interpret X-rays more readily. Now let me come to my first case. It's an 18-month-old boy who has admitted to a private nursing home. For some unexplained reason, he received co-amoxiclav and amikacin IV. However, the child improved, no distress, just occasional low fever persisted, but the parents were not happy and the doctor was also very worried. So he repeated an X-ray. Now this is the repeat X-ray on day 5. So as we all, I'm sure this audience knows that here you will do none of the above. You will not escalate therapy. You will not do any CTs. You will not think of TB. You will continue the same line of treatment because this is not actually a difficult pneumonia at all. So this is a pneumonia that it's taken time to improve. So what can I legitimately expect when I treat a pneumonia patient? I want the RR to settle, the SpO2 to improve shortly, the fever spikes to be less. There should be some return of appetite, less irritability. However, in most studies, the median time to resolution of symptoms in children with oxygen saturation of 85% or less is 9 days. So X-ray will not return to normal anytime soon. It is not a mode to follow up the recovery of a pneumonia in the short term. Radiological response always takes time. It may take 3 weeks for a RSV. It may take 8 weeks for a pneumococcus and up to even a year for adenovirus 21. So let's not call pneumonias which are straightforward difficult only on the basis of radiology. Now let's take this typical second case, which I'm sure all of us have experienced at some point of time or the other. This is a 5-year-old boy with a 2-day history of fever, cough, brought with grunting, RR increase, SpO2 89. He has received an older PCV 10 valent, not the new 10 valent, the old 10 valent. And he was admitted, given IV ceftriaxone, sick child, azithromycin and oseltamivir being the flu season. His CBC was 29,000, his polymorph 78, CRP 230, blood culture was sent, and fever spikes continued at 105 and above. So we were just following recommendations because in children with CAP, we do send blood culture, though we know the yield may be less than 7%. The other two things I will tackle a little later. But what do I do next? This child keeps on spiking. Should I straight away escalate to something like meropenem or piptaz? Or should I do an X-ray or should I do an USG? Now here, I think there's absolutely no confusion. We have studies after studies which tell us that a USG is the standard of care in a child who is not improving as expected, because we are looking for a collection somewhere. So what a lung ultrasound does is it picks up as less as 10 ml of pleural fluid, whereas an X-ray will require 200 ml of pleural fluid to be picked up. And sonography can also provide information on the nature. Is it a transudate? Is it an exudate? Are there loculations inside? A USG is in fact more sensitive to detect loculations than even a chest CT. So we are all familiar with this kind of pictures where you can get. And what do we expect to find when we do such a pleural fluid examination? What we find is that we will be doing a pleural tap in this child, we'll be putting an ICD and we'll be sending the fluid for examination. And in Indian situations, more often than not, we tend to get staph aureus. So this child was, there were hardly any loculations and ICD was done. Fluid was sent for various tests. Meanwhile, the blood culture grew strep pneumonia, sensitive to everything, sensitive to ceftriaxones, sensitive to most routine antibiotics, but the patient is not doing well. So what do I do next? This is truly a difficult pneumonia. I put an ICD. So this is the point where I might consider doing a CT scan because my pleural fluid is not giving me an answer. My blood culture has grown strep pneumonia, which is sensitive. So here, I'm just showing you 2 slices of the CT. Here I'm seeing the border of the normal lung, and I'm seeing posteriorly in an inaccessible place, a collection of pus and debris. The ICD was right above because we thought that was the source, but the pus and debris was right below. So this was the reason that this child was not improving in spite of an ICD and in spite of no loculations being detected. So what did we do next? This child was subjected to a VATS. The whole cavity was debrided, and this fluid was also sent for serotype, sent for gene expert, which came negative for TB, and even the blood culture was negative. So here, after the VATS, this child did well, the lung expanded, and thereafter the recovery was quite smooth. Now we wondered that in a child given PCV10, why on earth did this child get a strep pneumonia infection? So quite obviously, it was a strain that was not covered by PCV10. Was it 3? Was it 19A or was it 6A? So we did send this thing for serotyping. For the information of everybody, we do get serotyping done at a WHO center in Vellore Christian Medical College, and they accept samples. So we're actually waiting for the serotyping report. This is a relatively recent case. So to come back, are pleural complications the only complications of a pneumonia? Most certainly not. Complications can be systemic also, and we have to be on the lookout for ARDS, for syndrome of inappropriate ADH secretion, where there is hyponatremia, you might get a child who goes into HUS and you're looking for anemia as well as looking for rising creat. You're looking for a DIC. And something I found while I was looking up this subject was that there is secondary thrombocytosis in many patients whom we think is a normal phenomenon, but in adults, this is associated with a bad prognosis. So maybe we require pediatric studies to know whether the secondary thrombocytosis is a marker of a poorer outcome and higher incidence of pleural effusion and empyema. And while we are on the subject, a quick word on necrotizing pneumonia. Necrotizing pneumonia is something that is recognized more commonly nowadays, seen in strep pneumonia, especially serotype 3 and 19, then staph aureus, as well as sometimes due to mycoplasma pneumonia and Legionella. The manifestations are more severe, and these children often get pleural effusion as well as empyema or a pneumatocele. So, how do we now approach a child for difficult pneumonia who is simply not doing well? Should I go for a HRCT? Well, HRCT is really not the way to go, because if at all I'm doing a CT, I'm looking for very specific things. I may be looking for a necrotization with a bronchopleural fistula. I may be looking at a lung abscess that is forming, and I'm thinking of a surgical intervention that may be necessary. So I would actually go for a CECT if at all, but CT is not the standard that every pneumonia not doing well, we go for a CT. Should we go for a BAL? It's an invasive test, but more and more easily available. And there is nothing like as good as BAL to give us the microbiology as well as a CBNAT. Should we do a sputum culture? I'll just come to it in a minute. Should we do a Mantoux test? Algorithms will tell you, no, we will not do a Mantoux test. It does not make us any wiser. And should we step up antibiotics? Really not without antimicrobial knowledge and knowing the culture. So should I do a CT or a LUS here, a lung ultrasound here? And there is a limited situation where CT can be helpful. And that is when it looks where we are looking for a loculated hydropneumothorax, or we are looking at a bronchopleural fistula. Otherwise, an ultrasound is as good as a CT. So when should we do microbiology? Very, very vigorously. We know that the yield of culture is from between 2 and 7% in most studies. So should I do a blood culture? Yes, probably in a hospitalized child, but most of the time we will not grow anything. So we have to look for alternate methods of looking for the microorganism. In this case, it may be a pleural fluid, it may be a sputum, or it may be a multiplex PCR done from a nasopharyngeal or from a BAL. So is really sputum a good way of looking for the bug that causes pneumonia? The answer is very, very doubtful. First of all, the sputum should be sputum and not saliva. It should be a good sputum, and a good sputum is defined as at least less than 10 epithelial cells or more than 25 polymorphonuclear cells per low power field. If you satisfy this criteria and if you grow a bug, then there is a possibility that it may correlate with the actual infection that is happening in the child. Otherwise, you may get a random bug from the saliva and does not correlate at all. Sometimes you get a lung abscess, but because of the time constraint, I will not go into the details of this. I would like to, in fact, share with you my next case first. That this was a 6-year-old girl with cold, cough, and fever since 12 days, high grade with spikes, admitted to a private nursing home, received piperacillin, tazobactam, and amikacin. Transferred to us because the child did not do well. And to cut a long story short, her CRP was 120, but the counts were unremarkable. Blood culture did not grow anything. USG showed a consolidation with small pleural effusion. So this was the kind of picture here. And this child was admitted, given ceftriaxone and linezolid at that time. Sonography was suggestive of consolidation with small effusion. And this was, remember, an older child, and as fever spikes continued, we added clarithromycin, keeping in mind the possibility of mycoplasma. And we did a mycoplasma IgM, which was high. However, we all know that a single IgM does not have enough sensitivity, specificity, does not have enough predictive value to say that IgM was the cause, to say that mycoplasma was the cause of this pneumonia. But however, this was one point that we got. At that point, we were not in a position to get multiplex PCRs, and we found that the cold agglutinins were also negative. So ultrasound was repeated. The fluid was also sent for CBNAT, which also turned out to be negative. Nothing was grown on culture. And However, the patient very slowly started improving. The RR settled, the child improved in appetite, but the fever continued. So we had parents asking whether this was TB. There was a lot of pressure to start anti-TB treatment. But anti-TB treatment, let's all understand, and let's be very sure, is not started randomly today. We have to demonstrate the bug, and without a robust microbiology, we will not be starting anti-TB treatment. So this child's CT also was not very, very helpful. However, there was no evidence of AKT, but the child continued to run a little fever. We thought whether we should add steroids here, but there was absolutely no hemolysis, so we did not add. We waited and watched, and within 8 days, this child gradually improved. What we did was, this was the first mycoplasma report, and just to share with you, in another 3-4 weeks, a second mycoplasma report showed a rising titer. So in retrospect, we got a confirmation of the diagnosis. And this was a child with a mycoplasma pneumonia and empyema and a long course, which to my mind is an important cause of a difficult pneumonia and always to be kept in mind. But many of you who know the PERCH study will say that in this PERCH study, which was a multi-country study, did not involve India though, there were 9 study sites, and they found that the commonest cause of all pneumonia was actually viruses and not bacteria. And they found that mycoplasma was actually not very high in that study. Also, a CAPE study was done by Dr. Joseph Matthew, and this is a very well-known study done in PGI Chandigarh. And they really had a lot of patients whom they studied. But they also found that nasopharyngeal samples are inappropriate specimens. Blood culture has a poor sensitivity. It was only 2% in their case. And they found that the etiology was mostly viral in whatever studies they had done, but mycoplasma was pretty low in that study. So multiplex PCR is so easily available today at a cost. Should we be doing multiplex PCRs because we know that pneumonia is so much viral? There have been a lot of studies on multiplex PCR, and I don't have time to really go through each of them. But I can tell you in short that if you isolate RSV, it is likely to be pathological. If you say find rhinovirus, it will probably a bystander. And remember that symptomatic versus asymptomatic patients, there is a very, in some cases of viruses, equal detection in symptomatic and asymptomatic, but in some viruses, it may be different like RSV. So we are not very much on solid ground when we do a multiplex PCR and say that, oh, I found the cause of this pneumonia. But again, before I conclude, I want to share one case with you of a child where this multiplex PCR really helped. And this was another difficult pneumonia, a 2-year-old child with fever and cough since 4 days, admitted to a private nursing home, diagnosed as pneumonia, started on ceftriaxone, not improved, stepped up to linezolid, azithromycin, transferred to our tertiary care hospital. And this was the child with very high fever, but CRP was not very high, consolidation on both the sides. And the child had actually really got severe hypoxia, and we did not know the etiology of this pneumonia. Investigations, all possible investigations were quite, they were not really going, they did not give us any answer. And CBNAT was negative, USG did not show any effusion, mycoplasma IgM negative, and the child was by now on Vanco and Miro because very sick. Then we did a nasopharyngeal biofire, and it came positive for adeno and rhino. So rhino, let us ignore, it's a bystander, but adeno could well be the causative virus. But just on the basis of this report, I would not have the confidence to stop antibiotics and say this is purely viral. This child continued to be worse. So what we did was we did a bronchoscopy, and from the bowel fluid also, we did an adenovirus, we found adenovirus. So this was actually a case where the viral, this really helped us to come to a diagnosis. And this was an adenovirus pneumonia. Once we were sure of that, when we did a biofire and we did a culture from the bowel and there was no growth, we were on solid grounds to stop antibiotics, continued supportive treatment. Gradually, the child was weaned off NIV and made a very good recovery. The other kind of pneumonia that we sometimes have are mixtures. We have strange bedfellows where TB may be there along with some virus or some virus with a bacteria or a mycoplasma with a bacteria. And these are today not very, very clear-cut territory, and I would be looking very with interest at Dr. Kabra's remarks on this, that what about the mixed pneumonias? How do we diagnose, and does it really justify giving polytherapy in such cases? So, how much time do I have, please? Hello? I'll just quickly talk of non-resolving pneumonia, which is another kind of difficult pneumonia. What is non-resolving? It is a persistence of symptoms for more than a month in a child with LRTI. And in a slowly resolving pneumonia, radiographic abnormalities persist, but the child has clinically improved. So this is about non-resolving pneumonia that we have. And we also know that many of these non-resolving pneumonias, they tend to be tuberculosis. And as I said earlier, that we need to have a solid microbiological diagnosis. We need to do either an induced sputum or a gastric lavage and do CB-NAT, and then do not just label any non-resolving as a TB. The other causes of a non-resolving pneumonia, in the interest of time, I'll go very quickly. And I have a case, but I don't think I have time to show you this. To come back to an algorithm, which was, I think, shared by Dr. Kabra himself. If it's a single lobe non-resolving, we think of luminal or extraluminal causes. Luminal causes would be possibly a foreign body or an endobronchial TB or tumor and adenoma. An extraluminal cause may be something compressing on the bronchus, a lung sequestration, a bronchogenic cyst, a cardiac problem, or a vascular ring. So these all could be delineated by doing the appropriate studies, especially a structural study like a CT chest and a fiber optic bronchoscopy. So this would be the first kind of test that we think of if it's a single lobe, whether it's extra or intraluminal. And I showed you right in the beginning how you could demarcate the lobe on the basis of radiology. And if it's a non-resolving pneumonia that cuts across multiple lobes, then you start thinking of, say, a structural anomaly. You may have some sort of thoracic congenital anomaly. You may have chronic aspiration. Think of bronchiectasis and or immune deficiency or cystic fibrosis, where you do the appropriate test as required. So I'm not going to cover non-resolving pneumonia in good detail in these 15 minutes, 20 minutes allotted. I will just say that the real world summary of persistent pneumonia is that from India, and this was a series published in IJP, that gram-negative bacteria contributed the maximum along with aspiration. Tuberculosis was 19%, immunodeficiency 7%, and so on and so forth. Malformation and cardiac disorder about 5% each, 2% is foreign body. So these things have to be thought of when you get a persistent pneumonia. So to sum up, because of lack of time, I will just say that I have learned many lessons in all these years, and I just want to share some of them with you. That I would say, first, treat as per standard guidelines. Know what to expect when you treat a pneumonia. Don't expect too quick a relief. X-ray changes take time. USG is a grand tool for monitoring. Be familiar with what it can do. There is nothing like empirical AKT today. You need microbiological confirmation. And be aware of the limitations of sputum culture and multiplex PCR that is available. And CT scans are only done in selected cases. So with this, I will conclude, and thank you very much for the hearing and the opportunity.
Thank you, Vaidya sir. You have simplified the topic of difficult pneumonia in children very well. And I hope now this difficult pneumonia will not be so difficult. But we would also like to hear from Kabra sir. So I request sir for his expert opinion.
Thank you. Thank you very much. Dr. Vaidya has made it very clear. And the important lessons learned is that if it is a community acquired pneumonia, there is no role of X-ray upfront. If a patient is not responding as per expectations, then you can go for a X-ray film of the chest. And this thing, if there is a limitation, though commercially there is lot of investigations or tests available for identification of geological agent or nasopharyngeal aspirate, sputum, and other body fluids, but there is a limitation. And he touched briefly on PERT study, and that was very difficult to interpret if you identify 1, 2, or 3 organisms. And he rightly pointed out that if you have a 2 or 3 organisms, though it is very difficult to say that this is the causal agent or causative agent for a lower respiratory tract infection or pneumonia. If you find 10 to 40% of the time, you may find multiple organisms. And in those situations, you will go by the history, clinical features, and whatever is the organism isolated. So he said that rhinovirus may be just an innocent bystander, but it, RSV may be etiological agent. So depending on your clinical features and your isolate, you will decide that probably this is the etiology. We may not be 100% sure. One of the question in the chat box is that when you will use fibrinolytic agent, Dr. Vedya, Dr. Prakash sir, when you will consider in your second patient, whether you would have considered giving him a fibrinolytic agent
I mean, there are many studies which will say head to head. As sir, you must be, you yourself, I think, have conducted some of them. But if I think cost is not an object which is there, I would go for VATS every time, because VATS is the final answer. Because especially if loculations are there, then definitely you need to do a VATS, because a fibrinolytic may not go into all the locules. So if there is no loculation, now many of the studies which support fibrinolytics, they come from European countries. And I remember Dr. Varinder telling us that there the pathology, the agent is mostly strep pneumonia, where the fluid is not so thick. But in India, where we have a lot of Staph aureus, the fluid is very thick, loculated. I think fibrinolytics have a lesser role than VATS, where VATS is affordable and possible. Sir, I would like your expert answer.
You are right. There are 2-3 things. But if there is a initially inflammatory process and some secretions are getting thickened, at that stage, if you give a fibrinolytic agent, it should be helpful theoretically. Once it is a delayed, say a patient has come to you after 2 weeks, when already inflammatory process is over and fibrosis has set in and there is a thick peel on the pleura. In those situations, even if we give fibrinolytic agent, it may not be of much help. So that's why you rightly said that in European countries, specifically UK, it suggests that if you have a fluid and it is fluid in the pleura and it is a pathological, it is not a pneumonic pleural effusion. In those situations, upfront you will add urokinase, and that would be within 4 or 5 days of the illness. And in those situations, it will be of much help, and that's why they show that there is a significant reduction in the thoracotomy and surgical intervention. But in conditions where the patient has come very late, there is already fibrosis and thick peel, probably there may not be much role. So indication for giving a fibrinolytic agent could be the child has come in an early stage when there is not much of a fibrosis on the pleural surface. In those situations, you may try it and may avoid surgical intervention.
Thank you, Kabra sir and Prakash sir. Now we will go for our second topic, that is neonatal pneumonia. The speaker for this topic is Dr. Sandeep S. Patil sir. He has done MBBS ND Pediatrics, fellowship in PICU IAP, DM Neonatology from PGI. He is executive member of Maharashtra State NNF and treasurer of IAP Nanded, director of Care Advanced Pediatrics and Newborn Hospital Nanded. He has special interest in neonatal focus and total body cooling. Sandeep sir, over to you. You can share your slides.
Thank you, ma'am. I'm audible and visible. My screen is visible?
Yes, sir.
Okay. Good evening to one and all. Today we are just moving from the first topic of difficult pneumonia to neonatal pneumonia. See, neonatal pneumonia is a little bit different from pediatric pneumonia. And this topic we are going to discuss under following heads. So, these different heads we are going to discuss. Here, I will just make you sensitize that how these pneumonias present, and basically neonatal pneumonia, it's very difficult to diagnose from other neonatal pneumonia or pneumonia mimickers. So we'll be discussing more on the radiological features and we are going to discuss different types of pneumonia, being the etiology is different, management, thinking process of a neonatologist varies according to type of pneumonia. So we are going to discuss on that also a little bit, and the treatment part, empirical as well as selective treatment, we are going to discuss more. So my more focus will be there on diagnosis as well as where we are going to localize this pneumonia, as well as where we are going to put this pneumonia type, and then treatment will be simple according to that. So then we'll go ahead. So first we are going to define what is pneumonia. Since neonatal pneumonia, it is nothing but generalized, it's a part of generalized systemic involvement. See, neonatal sepsis is a generalized systemic involvement. Out of that, neonatal pneumonia is a part of a process. So it is not a simple that it's only a pneumonia where the lung involvement is there. So whenever you are suspecting neonatal pneumonia, you have to suspect sepsis in whole, which is involving most of the systems of a neonate. So pneumonia, whenever you are thinking, we should consider that other systems also are involved. And predominantly, the baby presents with some kind of lung signs involvement. So like that, you have to keep in mind, and you have to assess the child in that fashion only. So as I told, we are going to discuss the pneumonia types on early onset and late onset, depending on at what time the baby had onset of pneumonia. It may prolong for any time, but onset of pneumonia, if it is happening before 7 days of baby's life, then it is called as early onset pneumonia. And if the onset of pneumonia is after 7 days of life and before day 28 of life, then it is considered as late onset of pneumonia. It may prolong to any time, but onset, if it happens within a week, then it is an early onset. Why I'm dividing this, or this nomenclature is there, because the etiology as well as the diagnosis as well as depends on when there is an onset of pneumonia. So that's why we are focusing more on that. So just to know that what are the common risk factors for early onset neonatal pneumonia. So see, as I told, it's early onset pneumonia happens less than 7 days of life. Basically, prematurity and low birth weight is the most common cause for early onset pneumonia, because we know that the antibody transfer happens after 32 weeks of gestation of a child in womb. So if the baby is born before 32 weeks of gestation, they are little bit immunocompromised. They have less antibody stores and they're more prone for infection, and a part of that will be a pneumonia. Most of the time, early onset pneumonia are going to be secondary to maternal risk factors, which are more predominantly pain in them. That is maternal chorioamnitis. That is, mother is having more fever of more than 37.5 degrees Celsius. Then their TLC more than 15,000. She's having uterine tenderness, very foul smelling per vaginal discharge is there, and multiple unclean vaginal examinations are present. Then you have to suspect, if the baby is presenting to such kind of mother with some more predominant respiratory signs, then you should consider that this is early onset pneumonia. Then other like maternal group B streptococcal colonization, as well as unhygiene condition, mother coming from the periphery with poor hygiene, less antenatal checkups, coming for a delivery, baby is admitting with preterm birth with more respiratory signs, you should suspect pneumonia in such baby. Then late onset pneumonia, already the babies, as I told, they are more immature in their immunity as the gestation is lower. So less than 32 weeks of gestation baby who is absolutely normal or has improved over a period of 7 days. And after that, if the baby is ventilator dependent and the baby is having prolonged stay in NICU, such kind of babies are more prone for late onset pneumonia. Why? Because these babies are more prone for being the prolonged stays there. They are more on mechanical ventilation. Preferably, if they are on invasive mechanical ventilation, they are more prone for pneumonia. We can call it as a ventilator associated pneumonia. Or if the babies are having more other anomalies associated, like tracheostomy fistula is there, coronal atresia, and CPAM, that is congenital pulmonary adenoma malformation is there. See, any congenital malformation in the lung decreases the lung immunity of that child. Simply in tracheal fistula, even if we have not fed the child, baby is going to have secretions. So that secretions will get aspirated and the baby is going to have infection, secondary infection, and then pneumonia. So such kind of babies, we cater them in a prone position with head down position with continuous negative suctioning till they get operated for that. So just I want to put this early onset and late onset to make you sensitize that the thinking process is going to change depending on when is the onset of pneumonia and what was the scenario when the baby has developed pneumonia. After that, we'll go on some common etiologies which we commonly encounter in our NICUs. That is, first is bacterial pathogens. More commonly, we get E. coli and Klebsiella. Sometimes we get Staph aureus and group B streptococcus. Viral pathogens wise, in more preterm babies, we get respiratory syncytial virus and other viruses like HSV, CMV very rarely. Fungal pathogens wise, we get Candida species and aspergillosis, and rarely we get, as a part of torch infection, toxoplasma and syphilis. More commonly, we get bacterial and viral pneumonias only. Now, I had put this slide in front because, see, what our eye sees is that what brain knows. One thing is that whenever you find some telltale signs, so you should have some spot diagnosis, because see, in neonatology, you should be beyond the disease, not behind the disease. So whenever you see a baby is having abscess as well as empyema, you should have a suspicion that which organism might have infected this child. So most commonly, this is secondary to Staph aureus. So in that, your drug of choice, that is empirical antibiotic choice, depends on these spotters. So if you get pneumatocyl on X-ray, or if you find ultrasound features of pneumatocyl in that baby, you should suspect Staph aureus and select gram-positive covering antibacterial agents in that child. So if you find pneumonia with brain abscess in a child, more commonly they are caused by Citrobacter. And if the baby is presenting, if mother is having chlamydia infection, and she has delivered vaginally, and usually if the child is presenting after 2 weeks of baby's life, then mostly it is chlamydia trachomatis. COVID-2, see, we have seen few of the cases of primary infections of lung. Most of them, they have presented like viral pneumonia, and most of them got admitted in second wave of COVID, where of MISCM. And MIS we used to call it as. So clinical presentation of neonatal pneumonia is just you can find out some specific signs related to respiratory system involvement, and most of the signs are non-specific of signs of sepsis. So the baby will have temperature instability, baby is going to have temperature instability associated with poor cardiovascular baby's adaptation, such as prolonged CFT is there, poor pulses are there, tachycardia is there, then baby's blood pressure will have white pulse pressure. Like that, the things are there which are non-specific sign. But if baby is having associated pneumonia, baby is going to have more respiratory signs, such as tachypnea, there will be intercostal retraction, subcostal retraction, episternal indrawing, alarmism flaring, then grunting you may find, then you may find baby is going to have decreased air entry, depending on the seriousness of involvement of the lung. Another thing, in case of late onset of pneumonia, you may find that if baby is already on ventilator, baby will have more ventilator requirements. Means FiO2, which was there previously 40%, FiO2 requirement will increase. Second thing, pressures which were there, pressure requirement of the child is increased, and you will have more endotracheal tube secretions. Now, evaluations wise, we will see sepsis evaluate. We have to evaluate the child on these three grounds: microbiological testing, sepsis general evaluation, and radiological testing of the child. We'll see more focus on radiological evaluation, as see in sepsis evaluation, basically, as you people all do, we have to do CBC, CRP. In addition, we usually in neonatology for neonatal septic screen, we consider for micro ESR as well as I/T ratio. This micro ESR is nothing but in a centrifuge centrifuge tubing, we consider doing ESR. If it is more than 10, then we consider it as a significant. And I/T ratio also, if it is more than 20%, we consider it as a significant. Then microbiological testing wise, we consider specifically for bacteriological culture with bactec, and as well as we consider for rapid antigen test that track for different viral antigens. Now we'll discuss more on radiological investigations because they are going to help more in newborn pneumonia. So see, in case of bacterial pneumonia, just if you see this first X-ray, see in this first X-ray, you can see that a lot of infiltrates are there. See, whenever you are reading newborn X-ray, you have to first count how many intercostal spaces, posterior intercostal spaces are there. Normally, they should be 6 to 8. In case of pneumonia, bacterial pneumonia, more or less, they are well maintained. That is around 6 to 8, or sometimes hyperinflated is there. Or if lobar or segmental consolidation with collapse is there, you will get less than 6 spaces. So in this X-ray, you can find that 1, 2, 3, 4, 5, 6, and 7 intercostal spaces are there. You're finding here very chiral infiltrates with such kind of alveolar infiltrates you are able to find. Then complications in pneumonia, you can find lung abscesses as well as pleural effusion. In the last X-ray, you can find this sharp margin. So this is showing that this is actually pleural effusion. See, neonatal X-ray and pediatric X-ray is different in the sense we are going to take X-rays in a lying down position at all. So effusions are very difficult to pick up. We are not able to get erect X-ray of a neonate unless and until baby is very stable. So your vision, or whenever you are suspecting clinically, you should see very closely these X-rays. And we have got another tool, that is lung ultrasound, which we'll be seeing in a couple of slides later, that how to diagnose bedside these complications related with pneumonia, or how to diagnose pneumonia. Now, another pneumonia which commonly find in neonates is viral pneumonia. See, I have focused this related to RSV pneumonia, which we commonly find in extremely preterm babies who are less than 28 weekers, micropreemies who are less than 800 grammars, and they have admitted around their corrected age of 36 weeks. Usually there is a repeat admission during winter month. And usually they have features of first upper respiratory tract infection, tachypnea, and really I'm telling RSV pneumonia is a killing pneumonia in extremely preemie babies. So usually they may recover, but most of the time, if the X-ray is like this, see ground glass opacity is there. See, you can see intercostal spaces. See, first intercostal space is totally opaque. This is first, second, third, fourth, 5, 6, 7, 7.5 intercostal spaces we are getting, but it is like a ground glass opacity on the right side. Left pneumothorax is little bit showing that radio opacity plus radiolucent shadows are there. So sometimes they are associated with cardiomegaly if myocarditis is there, and sometimes it is associated with pleural effusion. So viral pneumonia usually is common in extremely preterm babies. So history is very important, and such babies usually come from the community at corrected age of more than 35 weeks of gestation. Now, just which I was telling that, see, this bedside tool we got since last 5 to 7 years. So we had been trained in lung ultrasound for diagnosing multiple conditions. Like we can diagnose pneumonia, we can diagnose complications related to pneumonia like pleural effusion, empyema, pneumothorax, hyaline membrane disease, and TTNP also. So these are our common diagnoses which we get in neonates, and these are usually the mimickers of pneumonia. So which I'm going to tell basics about lung ultrasound is, whenever you are putting a probe on chest, you are going to see two kinds of line. See, first, these horizontal lines are A lines. Okay, this we will not go in detail. Just I will tell these horizontal lines are A lines, and these vertical lines, these cylindrical vertical lines are B lines. So any abnormality, so these are actually the artifacts, and any abnormality related to that, we can make some diagnosis. First thing is that if pneumonia is there, so we can find such kind of confluence of these B lines, and you may find a large B line. Another thing what you can find in pneumonia is this pleural line. So this is a pleura. Actually here you can see this is a normal lung with which is pleura, and then these are the horizontal A lines. So the pleura will be thickened, and sometimes there is a break in the margin of pleura, and subpleurally we will find some consolidated areas. So this is a telltale sign of pneumonia. Then complicated pneumonia, what you can find is, in complicated pneumonia, you can find that the baby has got some effusion. So this is a pleural effusion and some unechoic foci if you are finding in that. So it can be mostly empyema. So such kind of things, see consolidation also we can find that some subpleural hypoechoic areas we are finding in this E kind of image. So this is subpleural hypoechoic area. So this can be a consolidation. So see, lung ultrasound is a very simple bedside technique where we can diagnose RDS and this all differential diagnosis related to pneumonia. We can find it out and we can treat bedside. We need not have to wait for X-ray. So since last 5 years, we are using lung ultrasound probe for diagnosis of multiple conditions related with the lung of the child. So CT chest is having very less role in neonatology, just to rule out the complications. So management wise, we have to divide it as a supportive care, as a general care. You have to give specific antimicrobials you have to use, but antimicrobial treatment specific needs at least 24 to 48 hours till our cultures come. Till that time, you have to consider for empirical antimicrobial therapy and treatment of associated complications. Here in this slide, I have tried to put which commonly first line agents we use in our NICU. So first line agent for bacterial pneumonia, we first line use as ampicillin and gentamicin, depending on our previous 2-year culture data, which we usually get in our area. And if we get a specific organism, so most of the time, if GBS is there, ampicillin we use. E. coli and Klebsiella, most of the time in late onset kind of pneumonia we get, where we use colistin or we have to use meropenem. Then if MSSA is there, we have to use ampicillin. MRSA is there, we have to use vancomycin. Then rarely for viral pneumonias, we have to use ganciclovir. See, in last 10 years, I have to use for only 2 babies this valganciclovir orally, and acyclovir couple of times we have to consider for using in neonatal pneumonia. So this is just empirically I have chosen that, but according to the culture reports, we consider for using that. So last 2 to 3 slides are there. Neha ma'am, is it okay if I go ahead?
Yes, sir, you can continue.
Yeah, see, this is important slide where we are going to differentiate between a lot of mimickers of pneumonia. Why I'm putting this slide in front? Because see, neonatal pneumonia is very difficult to diagnose. Basically, why? Because there are many things which overlap. And basically, where neonatal pneumonia on one side is treated with antimicrobial supportive treatment, and on other side, these mimickers can be treated with different kinds of agents. So first we are going to discuss is disorder of transition, that is transition from mother's womb to ex utero. That is 2 conditions we are going to discuss is here as a TTNB and RDS. So how the TTNB is different, how RDS, later on we'll take TTNB. So yes, so TTNB, how it is differentiated from congenital pneumonia. See, TTNB usually history wise you have to go that usually the baby is delivered by LSCS. Baby is usually full term or near term. When you do X-ray, it is normally inflated or hyperinflated. As I told you, when you see the X-ray of a newborn, you should first count how many intercostal spaces are there. So in this X-ray, you can find 1, 2, 3, 4, 5, 6, 6.5 intercostal spaces. You are finding this interlobar fissural effusion. So this is a telltale sign of this baby is going to have TTNB. Another sign is you can find this hilar, these excessive vascular markings you will find. So these are hilar vascular markings, and sometimes you will find cardiomegaly. See, the TTNB is a condition of less or delayed absorption of lung fluid. So you are going to find fluid in different parts of lung where you can find cardiomegaly also. So like this, TTNB has to be differentiated from congenital pneumonia by absence of choriomyelitis in a mother, most of the time full-term child, and delivered by LSCS, and having TTNB, most of the time it needs oxygen support, or few times it may need CPAP or HHFNC. Sometimes only it may need ventilation. So like this, you have to differentiate from congenital pneumonia. Second thing is RDS. RDS is nothing but hyaline membrane disease. See, hyaline membrane disease happens if so. History-wise, usually the baby is going to be less than 34 weeks of gestation, and after that, when the baby is delivered by any mode, baby is going to have severe SAS scoring, that is Silverman-Anderson scoring. In that, baby is going to have grunt, decreased air entry, and when you cast X-ray, you will find that, see, for these two X-rays I had put forward, this is a normal X-ray. This is a normal X-ray where you can find some, just by the layman's look, you can find that there's a blackening is there on this normal X-ray, and radio opacity is the whitening is there on the left side X-ray. So this whitening is nothing but ground glass opacity or white out lung. Intercostal spaces will be 6 or less than 6 in case of hyaline membrane disease. So in case, again, you can find that, so in this X-ray, it is not there. Air bronchogram, you can see here. See, this is a bronchus filled with air, and suddenly it has collapsed because lung has not inflated. So air in bronchus is air bronchogram. So like this, we are going to see in hyaline membrane disease. Most of the time, congenital pneumonia also can present like this. So empirically, we may have to consider for antimicrobial in such kind of X-ray or clinical scenario of mother is having some risk factors for baby having neonatal pneumonia. And then after getting cultures, we may consider for stopping antimicrobials. Then we'll move on to meconium aspiration syndrome. Usually you will find meconium stained amniotic fluid delivery, can be normal or section. Baby is going to have tachypnea, distress. And these babies, when we cast X-ray, in this X-ray, you can find that fluffy shadows, inhomogeneous opacities are there. See, in case of HMD, what you have seen? So white out lung, homogeneous opacity is there. But in meconium aspiration syndrome, inhomogeneous opacities are there. And areas of patchy atelectasis are there. So sometimes you may find pneumothorax if there is a ball wall mechanism is there in case of meconium aspiration syndrome. And such kind of X-rays, when are associated with good clinical history, if you have not attended the delivery, just see the cord of the child. If it is yellow or green stain, and if you put feeding tube in baby's stomach and you are finding that aspirates are meconium stain with X-ray like that, you have to presumptively go to the diagnosis of meconium aspiration syndrome. Now, this is my last slide. So basically, see, we have got one baby who was 32 weeks of gestation, who was delivered by preterm vaginal delivery, and this baby has developed grunt. And after starting grunt, this baby was admitted in one pediatric center. In view of grunt, mostly this baby may need ventilation, surfactant, and for that, this baby was transferred to our unit. So our unit policy is to do echocardiography as well as neurosonography and chest ultrasound when any preterm baby or any baby with distress get admitted. So we were also not knowing, we have not got any cardiac auscultatory finding, no murmur was there. So when we put a probe, the baby was having TAPVC, which was obstructive type, and the baby's X-ray was like this whiteout. We have when we have seen the X-ray, it was a snowman kind of X-ray, and in the previous unit, the baby was referred to us for administration of surfactant and ventilation by Ensure technique. But actually, we could not. We have just by screening, we could find out that this baby is having TAPVC. So why I put this slide in front? Because TAPVC of obstructive type will have homogeneous opacity or ground glass appearance on the X-ray. So basically, whenever you are finding a baby with ground glass opacity, with saturations who are 70, 75, not improving with CPAP support as well as surfactant, you can consider or rule out congenital heart disease in such a child. Why I'm putting such kind of X-rays in front of you? Because they are usually overlapping with congenital pneumonia. So congenital pneumonia as a whole, you should consider, you should completely see the history of the child, clinical examination of the child, some radiological supports, and definitely lung ultrasound is going to help you out to differentiate from other parts of overlapping mimickers of congenital pneumonia. That's all I want to tell. Thank you. Few take-home messages I want to put forward. So one has to consider that this congenital pneumonia is a spectrum of neonatal sepsis. So whenever you are finding congenital pneumonia, please try to find out any other abnormalities of other systemic involvement in the child. And high level of suspicion definitely is going to help you out to put what kind of diagnosis or what kind of pneumonia it is, or as I shown in one slide, what kind of bacteria or pathogen has caused that pneumonia or lung infiltrate. USG test is a very good non-invasive kind of tool to help basically for differentiating different kinds of pneumonia or finding out pneumonia as early as possible. And for minimizing the complication, diagnose early, differentiate what kind of it is, the kind of pneumonia or what kind of other kind of disease it is, and start early treatment in the child to get the good outcome in this child. Thank you very much. And few questions are there. I'm happy to share them.
Thank you, Sandeep sir. Neonatal pneumonia is one of the leading factors we all know that contributing to neonatal mortality. And as rightly said, maternal history should be reviewed carefully as it is important to identify the maternal risk factors associated with congenital pneumonia and other pathogens. So thank you, Sandeep sir, for an excellent presentation. Now I request our expert, Dr. Kabra sir, for his opinion.
Thank you, Dr. Sandeep. You have made it very clear. The important learning point here is that all shadows on X-ray in newborn is not synonymous with that of a pneumonia. We should be very careful in reading a neonatal X-ray, and the other causes which may mimic should be kept in mind, and specifically like heart disease. And now we are finding more and more cases of a in full-term child with something similar to that of a RDS. Think of surfactant protein deficiency. Ultrasound, all of us need to learn so that it can be point of care test. And the other important thing here is the pediatricians who deal with say persistent pneumonia, as this session is for pneumonia, and if they get a history that the newborn during neonatal period the child had a PTNB, think of primary ciliary dyskinesia. Okay, because I think time is less, so I'll thank Dr. Sandeep. I am very nostalgic feeling because I am meeting someone, Dr. Sandeep, because I feel that I belong to Nanded. I spent 4 or 5 years in 1968 to 72 in Nanded. Thank you very,
Very
much.
nice to hear to that, sir. It's a very holy place, Nanded. It's a Gurudwara is here.
Yeah.
We are happy here to practice since last 10 years, sir.
Thank you
Thank
very
you,
much.
Sandeep sir and Kabra sir. Our next speaker is Dr. Parmar Chandni sir. He will be talking on pneumonia mimics. Sandeep sir, yes. Parmar sir has done MBBS, MD Pediatrics, DCS, DAA, DPAA, and Diplomat of European Respiratory Society. At present, sir is Associate Professor in Pediatrics, Head of Pediatric Respiratory Division at Jirabai Wadia Hospital of Children, Parel, Mumbai. He is member of Air Pollution and its Effect on Children Guidelines Group of IIP. He is also master trainer of Palmo Star module and NTEP program. He is specialized in flexible bronchoscopy, cystic fibrosis, allergies, and asthma. Over to you, Parmar sir.
Thank you, madam. I'll start sharing my screen. So, I did my MBBS till this thing education till 12th standard in Nanded, sir. I'm from Nanded. So let's start with this today's. I'm a odd man out here because I'm presenting on pneumonia mimics. Everybody has presented difficult pneumonias and neonatal pneumonias. I'm presenting what is not a pneumonia, and when we should start thinking whether this is a pneumonia or this is something else that we are dealing, which is presenting as a pneumonia, but it is not a pneumonia. So without further ado, I'll directly go on to the cases. I feel cases are the easiest way of learning and teaching. This is a 9-year-old child. He's a first by birth order, and he's one of non-consanguineous marriage with informing mother. He has come to us with complaints of fever for 20 days. It's cough for 8 days and chest pain and breathlessness since last 3 days. So this child actually had visited another pediatrician and then was admitted there. So on admission to us, when the child has come with a history of 20 days of fever, His vitals were heart rate was 132 per minute, peripheral pulses are well fed. He was slightly tachypneic with the RR of 40. Blood pressure was 116 by 76. Saturation was 96% on room air. The child was little pale. There was a significant lymphadenopathy in the right occipital and the bilateral cervical lymph nodes, and there was some internal as well as axillary lymph nodes as well. So then on per-abdominal examination, there was a lever of 3 centimeters. There was no splenomegaly. Respiratory system examination, the child was tachypneic, but otherwise there were no added sounds. But the air entry, that is the breath sounds, were decreased in the right side, in the right axillary and the subscapular area. And other system examination was normal. So the child was admitted outside for 8 days, and the child started having fever on day 4 or 5 of fever. The child was admitted, received ceftriaxone for 3 days and piperacillin, tazobactam, and vancomycin for 5 days. The child was requiring oxygen support. As the child was not becoming afebrile, and the child was started having breathlessness, the child, the parents took the Amma from that hospital, and the child came to us. So this was day 20 of illness. So when he came to us, the child's hemoglobin was 6.5. Total counts were 4,500. That is also on the lower side. CRP was high, 131, and then ESR also was high, 108. So the child had anemia, leukopenia, high inflammatory markers. This was the chest X-ray of this child, which was showing a diffuse haziness in the right lower zone. And otherwise, the left side also, if you can notice, there is some haziness in the left lower zone as well, but it was not as significant as compared to the right side. It was a diffuse, not typically following a lobar pneumonia type category. So when he came to us, we started him on, because there was a anemia and leukopenia. We thought probably it is we are dealing with something like an atypical pneumonia. So we started this child on amoxiclav and clarithromycin, and this child was planned for a BAL because it was almost a history of 20 days, and we wanted to know what organism it is which is not responding to a good antibiotic of piperacillin tazobactam as well. But because the child was requiring oxygen and clinically the child was worsening, so we thought we'll delay, because many times we see that post BAL sometimes they worsen and we may have to shift the child to ICU as well. During the ward stay, almost after like 5-6 days, the child started developing a swelling in the right knee, and there was other also joints were having pains, but there was no swelling, but swelling was only in the right knee joint. So this was the CT of this child. As you can see, there was a significant haziness in the left lower zone as well as in the right lower zone. So bilateral lower zones, the haziness was significant. It was actually reported as a dense consolidation in bilateral lower lobes. So we thought whether this is still a pneumonia, and it's a multifocal pneumonia which is probably not responding to regular antibiotics. Maybe we are dealing with an organism which is resistant, or maybe we are dealing with an MRSA or something like that. So we thought maybe we can upgrade this, and then we see. But to our surprise, this child's, because the joint involvement came in. So that was the one thing which we thought, why a child with pneumonia should have a joint involvement. Are we dealing with a child who's got some viral pneumonia, and as a part of viral spectrum or reactive arthritis that is coming up, or is it something that is not pneumonia and there is another system that is getting involved, something like an musculoskeletal system that is getting involved? So to look for the other system involvement, are we missing out on some other diagnosis? So we did a peripheral smear to hemat, which was almost normal. Sickling we thought, because joint involvement and lung involvement, that was also normal. Bone marrow aspiration was done, which was normal. There were no blasts that were seen, and urine routine was showing 20 to 25 RBCs per high power field, and there was some proteinuria as well. All cultures were sterile. So blood culture and BAL culture and urine culture always sterile. So we decided, so the flexible bronchoscopy was done because we thought, let's isolate some organism and let's focus on that organism. Also, we had a doubt of tuberculosis in our mind, because it was going for almost like 20-25 days. So are we dealing with a tuberculosis here? So flexible bronchoscopy was done, and which was almost like normal. But what we observed during the scopy was that mucosa was quite hyperemic. It was inflamed and it was bleeding on minimal suctioning. Otherwise, the anatomy was grossly normal. So in summary, this boy is a 9-year-old who had a fever of 20 days, cough and shortness of breath. Chest X-ray and CT was suggestive of bilateral lower zone haziness. He had anemia, leukopenia, high inflammatory markers, CRP and ESR in triple digits, normal bone marrow aspiration, and a new thing that has come up during the hospital stay was a joint involvement. So we thought whether we are dealing with something unusual, and this is not a pneumonia, but presenting as a pneumonia. So are we dealing with some sort of autoimmune etiology? So we decided to send a ANA blot in this child. So ANA came positive. DNA came strongly positive. 754 was the titer. Anti-histone bodies, antibody, and DCT came 4+. This was planned because the child was persistently tachypneic. So why we sent the ANA, I'll tell you, because the child was persistently tachypneic, and we thought because the child is anemic, we'll transfuse this child. So when we sent the blood for cross match, we got a call from the lab that we are not able to cross match this sample. We'll have to send this sample for cross matching to a bigger lab. So we asked them, why are we not able to cross match? They said probably the blood has some antibodies, and that is the reason. And that is the point. We thought probably we're dealing in a child who's got anemia, leukopenia, presentation like a pneumonia, knee joint involvement, and inability to cross match the blood. So are we dealing with some form of autoinflammatory syndrome? That's when we thought. And that was the time. This was the cross match report which they had sent from the lab, which was showing a DCT 4+ autoantibodies present, and the patient sample showed cold antibodies. So this is the time when we sent this ANA report, and that came positive. So based on this report, the diagnosis was made of an SLE. And when the diagnosis of SLE was made, there was a urine which was showing 20 to 25 RBCs. We decided to go ahead with a renal biopsy. Renal biopsy was done, and it was found to be a focal proliferative lupus nephritis class 3 with an activity index of 7/24 and a chronicity index. Chronicity index means it's a recent onset. Then the BAL also came, and that was showing a hemosiderin-laden macrophages. So this child was actually bleeding into the lungs. It was not a very major bleed to cause hemoptysis as a presentation, but what it presented as, the disease primarily presented as fever, cough, and anemia. That was the presentation of this child. So final diagnosis was SLE with pulmonary hematological involvement and renal involvement as well, and this child presented as a diffuse alveolar hemorrhage. Okay, so this was a case which presented as pneumonia, but later on turned out to be a SLE case and not a typical pneumonia case. So there were certain points in the course of the illness that made us thought probably we're not dealing with typical pneumonia, something else. If this child would have come to me on initially in day 10 of illness, probably I would have also managed this child as a community acquired pneumonia. As the disease progressed over a period of 20 to 25 days, maybe almost a month, the child was in hospital, some other hospital, and then us, and then we got multiple organ involvement, and that's how we reached to a diagnosis. Next case is a 3-year-old girl. She's second by birth order, non-consanguineous marriage. She's a well-immunized girl with no prior symptoms, and she came to us with a fever since 1 month, cough since 25 days, and the child was having shortness of breath since last 15 days. Also, there was a history of poor appetite and loss of appetite, and there was a history of tuberculosis contact. No, there was no history of tuberculosis contact with this child. So this child was admitted in a nursing home on day 10 of illness, where she was treated as a case of a bronchopneumonia based on the chest X-ray. So day 10 of illness, went to a nursing home, admitted there, treated as a bronchopneumonia with a history of fever and cough and shortness of breath. And the child received ceftriaxone and cloxacillin. The child was not improving, developed respiratory distress. So parents took the child AMA and went to some other hospital where the child was again admitted. So this was the chest X-ray on day 10 of illness, on which the diagnosis of bronchopneumonia was made. So there was, as you can see, there was bilateral diffuse involvement of the lung. It was more of a reticulonodular shadows, and there's almost like every part of the lung is involvement, more so on the right side as compared to the left side. This child was again, when the child went to second hospital, there was no history of TB contact, but they thought probably initially they thought based on this X-ray, they thought probably they are dealing with something like a miliary TB. Montu was given, which was positive. There were some patchy areas of consolidation. They thought probably the miliary tuberculosis which started now are becoming into a confluent areas of small areas of patchy areas of consolidation, and they thought probably we were dealing with the TB. They did a gastric lavage which was negative that point of time, but because the Montu was positive and there was a clinical syndrome, That's why they started the child on first line AKT. The child persisted to have fever, and then the child was discharged on AKTs, and again after 10 days of the AKT, the child was persistently having fever, respiratory distress, and then the child came to us at that point of time. So this was almost like a month history. So initially he was treated as a bronchopneumonia, not resolved, then treated as a miliary tuberculosis, not resolved, and this is the third admission the child was getting admitted with us. So on examination, the child was afebrile, the heart rate was 140 per minute, respiratory was 48, peripheral pulses were well filled, the CRT was less than 3 seconds, blood pressure was normal. If you see this, the child's growth chart, the child was falling well below the percentiles. Okay, so height was less than third standard deviation, and weight was also less than third standard deviation. The height age was 16 months, our child's age is 3 years, and weightage was 12 months. The child had icterus, pallor, liver was 5 centimeters, and spleen was 3 centimeters. So this child who has a chest X-ray which is looking like a miliary tuberculosis, on AKT, child developed icterus, pallor, and organomegaly. So we thought, are we dealing with a disseminated tuberculosis? From lungs, it has spread to the reticular system and involving the liver and the spleen. And is this icterus a part of the syndrome or clinical syndrome, or is it because of the AKT that the child is having this jaundice? This was the investigation when the child arrived to us. Hemoglobin was 5.8, total counts were 27,000. ESR was 109. PT and PTT both were grossly abnormal. INR was quite high. The total bilirubin was 4.7. Direct bilirubin was 3.2. The SGPT and SGOT also were high. SGPT was 272. Okay, so this child had a liver involvement as well as this child had a lung involvement. So the AKT was withheld because there was a grossly deranged LFTs. Vitamin K was given for 3 days. In view of deranged PT-PTT, 1 FAP transfusion was given. After that, the PTINR came back to normal. X-ray was suggestive of bilateral diffuse infiltrate, and ultrasound abdomen was suggestive of a moderate hepatomegaly with a coarse liquefaction. This was the chest X-ray, and this was showing almost like a miliary pattern of X-ray. Okay? So there is a difference between a typical miliary and something like a miliary looking X-ray. So this looks like not like a miliary. This looks like a miliary type of X-ray, but not a typically miliary, because as you can see in miliary you see multiple reticular, mainly see you see nodular patterns. Here what you are seeing is mainly the reticular pattern rather than a nodular pattern. So we thought, is this really a miliary tuberculosis? Let's proceed further. Okay. On day 7 of admission, the LFTs improved, but the fever and the respiratory distress persisted. So initially, which was thought to be a bronchopneumonia, then was thought to be a miliary tuberculosis with drug-induced liver injury, or are we dealing with something? Are we dealing with something like an interstitial lung disease? But why interstitial lung disease is spiking? Why interstitial lung disease is having persistent fever spikes? So we thought, are we still dealing with the infection, or this is not an infection? This is something else which is presenting like an infection, but not an infection, and something like an inflammatory disorder. So flexible bronchoscopy was done, and all cultures were negative. The BAL culture was negative, that is a bacterial culture. The gene expert ultra was negative, and the 3-week MGIT also later on came to be negative. This was the CT which was done later. So we can see, all of us can see, there are a lot of reticulonodular shallows, and there are a lot of what you can say that there is a septal thickening, and there is a fissural thickening is there. Okay, so this was reported actually as a miliary tuberculosis by our radiologist, and you can see that there is a fissural thickening. The fissure appears quite prominent. There are a lot of reticulonodular shadows. There's some cavity-like lesion on the right side as well as on the left side. You can see that. So this was reported as a miliary tuberculosis by our radiologist. But something was missing, like a gastric lavage was negative, as well as the bronchoalveolar lavage was negative, and this patient did not improve to first line AKT, and there was a development of a drug-induced liver injury. So we thought, are we dealing with an MDR tuberculosis, or this is not at all tuberculosis and something else? So what made us think that this is probably not tuberculosis was the involvement of the liver and spleen. Okay, this child had a hepatosplenomegaly, this child had an anemia, and this child had a lung involvement. So we thought, are we dealing with something else? Okay. we decided to go ahead and do a lung biopsy in this child because we thought probably we are dealing with a child who is not a straightforward case of a tuberculosis. And this was the lung biopsy which was done. It was an open lung biopsy which was done. And we got HNE stain done, which showed plenty of the lung was filled with histiocytes. And this was a special staining which was done, immunohistochemistry was done, which was stained with S100A, which is commonly used to stain the cells, the histiocytes, and the diagnosis that was reached as a LCH. Okay, it started as with a pulmonary involvement. This child never had any skin involvement. This child never had any other ongoing involvement. Commonly, we see a liver spleen involvement coming prior to pulmonary, but some children can directly have a pulmonary involvement, and isolated pulmonary involvement also been noticed. Okay, so when we talk about pneumonia mimics, like there are n number of definitions of pneumonia. To call it a mimic, I think it is better that we stick to one particular thing, and that is the radiological appearance. So what other things which can present like pneumonias and possibly may not be pneumonias, or pneumonia in an already involved lung, which already is affected, and then on the top of that the child is got or the person is got infected, and that is presenting as pneumonia. Underlying there may be something else. So malignancies can present as pneumonias, congenital lung malformation, something like CCAMs, bronchogenic cysts, sequestrations also during acute infections, and sometimes you may not be able to find out what exactly malformation is there unless we treat that acute infection and as the lungs clear. Autoimmune disorders can present with diffuse alveolar hemorrhages, and like the first case we presented, and that can also present like a pneumonia with fever and toxic child, and other ongoing involvement also can be there. Fungal and parasitic pneumonias also can present as pneumonias, hydatid cyst, which can be secondarily infected and can present. Lung infarcts, something like an acute chest syndrome can present in patients with sickle cell anemia as pneumonias. Immunological and inflammatory disorders like sarcoid, and rarely sometimes can embolism and pulmonary edema also can present as pneumonias. So in conclusion, bronchopneumonia or pneumonia, what we should look for is persistence of symptoms or recurrence of the symptoms. The patient is not improving with a standard line of treatment, and in such cases should be worked up in detail. History and physical examination will aid definitely in reaching to one particular diagnosis. We should be looking for other organ involvement, and that can actually that can also be actively looked for. Like in this child, somebody will ask me, why will you do a urine routine in a patient with a pneumonia? So we will do a urine routine in a patient with pneumonia when the pneumonia is not behaving like a pneumonia and it is behaving like something else. Okay, so that point of time we thought maybe let's look at some other organ. So we'll have to maybe actively look for other organ involvement. And presence of fever does not always mean infection. It does means inflammation, and we should be looking for the focus of inflammation than looking for the focus of infection. That's all from my side.
Thank you, Parmar sir. Pneumonia mimic is a very vast topic, and through various cases, you have made the topic very simple and quite interesting. So thank you, sir, for a wonderful presentation. Now I request Dr. Kavra sir for his opinion.
Thank you, Dr. Parmar, for very interesting cases. So, as a general pediatrician, if I am seeing a child with pneumonia, I am justified in giving a course of antimicrobial if there are some shadows on X-ray. But I should be willing to modify or change my diagnosis if it is not behaving like as it was expected. And if there are some unusual clinical features in form of, say, anemia, there is a organomegaly, there is a say significant failure to thrive, and if you find clubbing or other thing, then revise your diagnosis, think of some other condition which may be mimicking pneumonia rather than the treating it with a one antibiotic then changing it to something else. And in these two cases, the first case was very typical that if anyone having a respiratory problem going on for 3-4 weeks and having a significant anemia with leukopenia, then think of, and inflammatory markers are raised, think of rheumatological disorders. And in the second case, all miliary shadows are not synonymous with tuberculosis. Think beyond it. Specifically, if you're finding some nodules along with a thin walled cavity, and there is a organomegaly with hepatosplenomegaly, and there is a altered liver parameters. Think of LCH specifically so during infancy. Thank you very much.
Thank you, sir. Now I request Nilima ma'am. Over to you, ma'am.
नेहा YouTube questions कुछ है?
No, I cannot find any YouTube question.
In the chat box, Dr. Rohit Agarwal has given one comment. Apart from many causes of difficult pneumonia, adenovirus and H1N1 viruses are important etiological agents, and that should be kept in mind while managing the difficult pneumonia. So I think that is one important message he has put. Anyone in the audience in Zoom meeting?
Madam, Dr. Rohit Agarwal sir is there itself.
We can ask him, yes.
And he can give his comments.
Dr. Rohit Agarwal sir, will you like to comment or say something?
Thank you very much. It was really a brilliant and wonderful discussion and deliberation. My friend Dr. Sushil Kabra was there as a mentor, and when I revisit my old days, I really enjoyed working with him under first project we had of IIP on respiratory RTI module we had come out, and there I had a opportunity to work closely with him. He's a really walking encyclopedia of the pediatric pulmonology. It was wonderful hearing all the speakers were absolutely excellent, and I think very justifiedly they did. But probably I thought the first speaker, Dr. Prakash, my very close friend, would have stressed upon how to approach to a case of difficult pneumonia rather than showing the investigation and all that. That I thought, and my only message is that whenever any pneumonia, non-resistant resistant pneumonia, non-resolved pneumonia, difficult pneumonia, necrotizing pneumonia, always think beyond. Of course, the etiology could be pulmonary, but always think beyond pulmonology or beyond the lungs, because it could be a systemic disease presenting as on the platform of the lungs. So that is one should always remember whenever there is no response to your rational antibiotics, your rational diagnosis, and your right diagnosis thinking. And in fact, all the right investigation and all that, despite you're not finding any diagnosis, always think about either mimics, pneumonia mimics, or the something systemic disease beyond the lungs. That is a very important, which often we forget, and we go on adding the antibodies one after the other, one after the other. That practice should be really these things. There is a lot of misuse of CT scan I've seen in pulmonology. Nowadays, so many patients I get, CT done. That is a very bad habit, or I should say, very detrimental trait we are getting now, and particularly it has been we are getting it from the adult physicians. Number 3, AKT, of course, is a very, very wrong thing to start AKT just on the MAN2. It's a screening test, we should remember. And one must think it's a criminal act now if I start without documentation of tuberculosis, start AKT. So one must think 100 times before starting AKT. I mean, there is no justification of empirical AKT. That's the worst thing we could really commit act of commission in our practice. So these are the few things, and one must always give more precedence to ultrasonography rather than CT. And only relevant investigation, otherwise irrelevant investigation might lead you to something, or may fox you or put you to the ditch. So rather limit yourself for the very specific narrow spectrum investigations and more of a clinical acumen. What could be the cause, why I'm not getting the response. That's very important. That's all is my message to all of you.
Yes.
Thank you, sir. And it's very important message. TB, if diagnosed, is a notifiable disease. It should be notified. It is compulsory, mandatory. And number 2, and if we want to start AKT, please be careful. Otherwise, it will be a criminal act if it is not proper, if it is not documented properly. Sir, one question is there in the chat box. Other case scenario, either of a person you can take as a faculty. 2.5-year-old female child with recurrent fever, cough, cold since past 15 days. Counts 12,300, ESR 45, CRP 9, and X-ray chest bilateral hilar prominence and soft tissue opacities in right paracardiac region. MAN2 11/10. What should be done further? kindly opine. This is a question from Dr. Sujata. Probably this is a case scenario always we see in our general practice as a general pediatrician. So I have taken it look may awkward, but this is a scenario which you often see. So we want the expert opinion on this.
Yes.
Anyone would like to take that? Others.
Sandeep,
Dr. Kabra sir, let expert only say.
Okay.
Yes, sir.
So as this 2.5-year-old boy, a girl is getting recurrent pyrexia. Along with that, there are some shadows on X-ray, including prominent hilar shadow and right paracardiac soft tissue shadow. Tuberculin skin test is just 11-12 millimeter. So he needs the investigation, look for whether what antimicrobials the patient has received, whether it was appropriate, whether it is not a effect time or other thing, and just see that the doses and other things have been given appropriately. Investigate for tuberculosis, including gastric aspirate for CB0 or gene expert, if it is positive, because these things doesn't merit empirical anti-TB drugs. And then think of whether there is some other mimicker, including some non-infectious cause. As it, against tuberculosis, it is not an unremitting cough or unremitting fever, though it is for 2 weeks, but it is a recurrent. Along with that, there are a few shadows. So I would suggest that check the antimicrobial, do investigation for tuberculosis, look for other mimicker like a non-infectious cause rather than putting him on an anti-TB drug. And he should respond to these good antimicrobial agent.
Dr. Sujata herself is there on this Zoom dash. If she wants to clarify, she can speak. Dr. Sujata. Hope so, sir has clarified. Anything, Dr. Sujata madam, you want to ask? Pallavi madam, त्यांना permission दिली का सरांना permission दिली आहे?
हो sir, permission आहे.
Yes.
All are can unmute themselves.
Dr. Sujata, if you want to ask directly, you can just unmute yourself and ask. No idea, she is not responding.
If patient has already received appropriate antimicrobials and even then the shadows are persisting, fever is recurring again, think of doing more investigation. If there are no other obvious cause, then possibly you may go for this thing, bronchoscopic lavage, if it is possible, CT scan, and that should give a very clear idea whether it is really a infection or some other mimic.
Hello.
Yes.
Dr. Sujata.
Yes, sir. Good evening, sir. Sir, this child has received cefuroxime 10 mg per kg per day for around 5 to 7 days. Clinically, the child is active and playful. But other diagnosis, sir, what other can be the possibility? I will go ahead with the other investigations as advised by you, sir.
Yeah, investigate if he has received appropriate antimicrobial and even then symptomatic, then you may have to investigate for tuberculosis because it is going on for 2 weeks and X-rays are showing some shadows. To investigate for tuberculosis by doing a gastric aspirate for gastric aspirate or induced sputum for CB0 gene expert.
Yes, sir. Yes, sir. Thank you very much, sir. Thank you.
Anybody else wants to ask or get their queries clarified?
Anybody who is present on this Zoom dial just can unmute themselves. They can ask directly if they want or comment if anyone wants to do the comment.
Nanivdekar sir or Pramod Kulkarni sir, you want to comment or say something?
Good evening, everyone.
Good evening.
Sorry, I don't have to add anything. I think all the deliberations were excellent, especially the pneumonia mimics was superb. Basically, when you are not getting the response as is expected with antibiotics, we have to think laterally. That's the message which all of us follow.
Yes.
Thank you.
So it was a wonderful presentation by all our three speakers. And Dr. Prakash Vaidya said how the unresolving pneumonia, how to proceed with that. Mycoplasma pneumonia, viral pneumonia being the commonest cause, how to wisely use multiplex PCR, lung ultrasound, BAL, cultures, everything. He has guided us on that. Dr. Sandeep Patil sir gave us guidelines about congenital pneumonia, early and late onset, think of different causes and go ahead with the investigation. And Dr. Parmarth gave us all the insight into what can be presenting as pneumonia, but not actually pneumonia. It's some other disease. Again, I think we have to go back, as S.K. Kabra sir said, it's not behaving typically, then we have to go back to clinical examination, find out about organomegalies, investigation में कुछ different दिख रहा है क्या? So we have to keep eyes open. Don't keep on changing antibiotics, 2 sets, 3 sets, or give AKT blindly. So that was the message we got, and how to proceed with the investigation we got out of this session. So thank you for excellent presentation, Dr. Prakash Vaidya sir, Dr. Sandeep Patil sir, and Dr. Parmarth sir. Sushil Kabra sir joined from New Delhi, and he guided us. After every speaker, he guided us again, take home messages he has given us. So thank you, sir, very much. Dr. Gangolia sir for being present here, Dr. Neha Singh, Mahesh Mohite sir, Pramod Kulkarni sir, Narendra Nanivadekar sir, everyone present on the Zoom dais. We appreciate your presence and thank you everyone. Dr. Pallavi, who is Maha AP technical support, she is always there with us. So thanks everyone.